Hello, good evening. Hello, good evening.
Good
Hello,
evening.
good evening.
Hello, good
Yeah,
evening.
yeah, how are you doing?
We are
We are
blessed and
fine by
highly
grace. How
favored.
about you?
I'm also doing well. Okay, so the last time we met, we started with BPH. So we spoke about BPH meaning benign prostatic hyperplasia. We said the term BPH refers to an increase in the cell number of the prostatic tissues. And this increase is a benign increase, so it's non-cancerous or non-malignant. We also spoke about the functions of the prostate. We said the prostate gland is a walnut-shaped organ located anterior to the rectum, distal to the bladder, made up of four main zones: the transition zone, the central zone, the anterior fibromuscular stroma, and the peripheral zone. And we also mentioned that in terms of the functions, prostate gland produces prostatic fluid. This prostatic fluid is alkaline in nature. It is able to neutralize the harsh acidic environment in the vagina, helping protect the sperm. We also mentioned that the prostate gland also produces PSA, which is very vital when it comes to diagnostic purposes. And we also mentioned that prostate gland is able to provide some antimicrobial properties. That prostatic fluid contains high concentration of zinc, and that zinc is able to provide the antimicrobial properties. So these were some of the functions. We also mentioned it provides the prostatic fluid, which serves as a vehicle for the sperm to swim. So all these are some of the functions. Then we moved on to talk about the clinical presentation. Basically, we said that if someone has BPH, they may present with two main symptoms. It's either the storage or obstructive symptoms, or the voiding, storage or irritative symptom, or the voiding or obstructive symptoms. So we mentioned some of the examples: the storage symptoms, urinary frequency, urinary urgency, nocturia, incontinence. Then the obstructive symptoms, urinary intermittency, urinary hesitancy, post-voidal dribbling, and all that. Then I think we started with the diagnosis. We said that the main thing that you need to take note first is the history. Because if we have a 20-year-old person presenting with urinary frequency, urinary urgency, you wouldn't think about BPH because BPH, most patients are usually within the ages of 50 years and above. So if you are having a 20-year-old presenting with these symptoms, you'll think more of UTI rather than BPH because these conditions can also present similarly. The same way, if you have a female complaining of urinary frequency, urinary urgency, you will not think about BPH because females do not have the prostate gland. So these were the things that we talked about in terms of the history. Then we said you can do a bedside examination, which is DRE, digital rectal examination. And basically, digital rectal examination, with the aid of gloves, the doctor is able to insert a finger into the rectum and able to check the size, the texture, in terms of whether it's smooth or rough. They are also able to check the nodularity, whether there are nodules and all that. Because it's not only BPH that can present with these manifestations. Prostate cancer, prostatitis, all these can present similarly. So in terms of DRE, we want to be sure is the prostate gland enlarged? Is it smooth? Is it rough? And all that. And we talked about how you can use the finger breast unit to determine the size of the prostate gland. After all these, we said you can also do PSA levels. We said PSA is released by the prostate gland. So whenever there is an injury, being it's an infection, enlargement, you can have PSA being what's elevated. However, PSA levels are non-specific. It's not specific to BPH. It can be elevated in other conditions. Then we said the gold standard is the abdominal pelvic ultrasound. So you can do ultrasound of the pelvic, and that will give you the size of the prostate. It will give you the appearance, whether they are nodules, whether it's just an enlargement, and all that. So I think that's where we ended the last time, if I'm correct. Did we start with the management?
No,
No,
please.
please.
Oh, please.
Hello, Dr.
Okay.
Isaac.
Yeah.
Hello, good evening.
Good evening.
Please, with respect to using the index finger to check the prostate size, can you please just enlighten me more? My understanding was not too good over there.
All right. So I said the average size of the prostate gland is 20 to 25 grams. So that's the average size of a normal prostate gland, 20 to 25 grams. So with the aid of the glass, the doctor inserts his finger into the rectum. And basically, when you look at the finger is divided into three finger brace units. So the index finger. So if you look at your index finger, you can see three main demarcations. And each demarcation represents one finger brace unit. So there are three finger brace units on your finger. So when a doctor inserts the finger, he tries to check the whole circumference of the prostate. If that circumference is spanning within just one finger brace unit, then that's a normal prostate gland because one finger brace unit is equivalent to 15 to 20 grams. So each finger brace unit is equivalent to 15 to 20 grams. So the patient's prostate is spanning within 15 to 20. You know it's normal because the average is between 20 to 25. However, if the doctor is getting two finger brace units or three finger brace units, then you know it's enlarged because two finger brace units will be equivalent to 30 to 40 grams because one is 15 to 20. So two will be 30 to 40 grams, which is above the average, which is 20 to 25 grams. So if you are getting 2 to 3 finger brace units, then that means the prostate gland is enlarged.
Thank you very much, Doc.
No, you're welcome.
Doc, please,
Okay.
could you
Any
go
other
over
question?
Oh, sorry. Doc, please, could you go over the difference between the irritating and then the obstructive symptoms? Thank you.
So we talked about storage or irritative symptoms. We mentioned some examples being urinary frequency, urinary urgency, nocturia, and urinary incontinence. These are related to your inability to store urine. So that's why we call it storage symptoms or irritating. So if you are unable to store urine, that means like within an hour, you can go to the washroom like 3 or 4 times. So the number of times that you frequent the washroom is high because very little urine in the bladder, you feel like peeing, you're not able to store. So you have urinary frequency. So that That's irritating. You could also have urinary urgency. You are almost always having that urge to go and urinate. You may also have nocturia, so you would have to wake up several times at night to go and urinate because of your inability to stop. Then urinary incontinence, because you are not able to hold the urine. Realize that you start whenever you feel like peeing, you are not able to hold, especially if there's no washroom around. It's likely you may do it on yourself. So these are storage or irritative symptoms. Then the other manifestation is the obstructive or avoiding symptoms. So the obstructive or avoiding symptoms, they are related to the process of peeing. So in the process of trying to urinate, you realize that you may have urinary hesitancy. So urinary hesitancy means that you can go and stand in the washroom, you wait like 10 minutes before the urine starts coming. So there's that hesitancy to initiate the urine. You could also have splitting in the stream of urine. So if you have BPH, you realize that maybe you are trying to urinate, some of the urine stream is going to the west, some are going to the east. So there's a split in the urine stream. It's not a continuous stream. And you may also have intermittency. Intermittency comes small, then breaks, then you have another, then it breaks. So it's not continuous. There's breaks in between. So there's urinary intermittency. Then we also talked about post-voidal dribbling. So after urinating, you realize that you still feel like some drops are coming. So post-voidal, after urination, you have dribbling. And you may also have the feeling of incomplete evacuation. When you are done urinating, you feel like there's more urine left. So these are the obstructive or avoiding symptoms.
Yes, please. Thank you very much.
Okay. All right. So let's talk about the management. So usually when you have a case of BPH, there are three strategies of management. The three strategies, it will depend on the severity of the BPH, if it's mild, moderate, or severe. So usually there are three strategies. So the first one is watchful waiting. So watchful waiting. So a patient with BPH diagnosed maybe from the ultrasound. Ultrasound shows that the prostate gland is enlarged. The patient may not be showing symptoms, or the patient may be showing very mild symptoms. And these mild symptoms are not bothering the patient. It's not affecting their day-to-day activities. Neither does it affect their quality of life. So they are not bothered about their symptoms. So for such patients, you do what we call watchful waiting. Watchful waiting, you just monitor the progression. You don't do any treatment, you don't give any drug, you don't do nothing. You just have to monitor the progression of the symptoms. So that's the first strategy. So watchful waiting. So people with very little to no symptoms, and they have um, those with symptoms, the symptoms are not bothersome. You do what we call watchful waiting. The next is for people with symptoms where they start having issues and start bothering them and all that, then you can consider pharmacotherapy. So the second strategy is pharmacotherapy. The first one is watchful waiting. So those with bothersome symptoms, you can consider giving medications. So that's pharmacotherapy. And the last bit is surgery. So surgery is the last for the very enlarged ones, very severe symptoms, not responding to medications, then you may want to consider surgery, especially the very large ones. You've tried the medications, it's not really working, then you can consider surgery. So these are the three main strategies: watchful waiting, pharmacotherapy, and surgery. So we start with pharmacotherapy because that's the focus. So for the pharmacotherapy, there are a lot of classes of drugs that are used. So we have the alpha blockers. So one of the classes is alpha blockers. Alpha blockers are also are very much used. The second one is 5-alpha reductase inhibitors. So 5-alpha reductase inhibitors. Then we also have phosphodiesterase type 5 inhibitors. Phosphodiesterase type 5 inhibitors. Then we also have anticholinergics. So anticholinergics. And the last class is the beta-3 agonist. Beta-3 agonist. So 5 main classes: alpha blockers, 5-alpha reductase inhibitors, phosphodiesterase type 5 inhibitors, anticholinergics, and beta-3 agonists. So we take them one after the other and talk about them. So we start with the alpha blockers. So when I was talking about the etiology, remember I mentioned increased adrenergic tone. So there's increased adrenergic tone. So as the prostate gland enlarges, it doesn't just enlarge, but there's also increase in the number of alpha receptors. And if we are increasing the number of alpha receptors on the prostate gland and around the bladder neck. So around the prostate gland and around the bladder neck, we have alpha receptors. So as the prostate gland increases in size or increases in the cell number, you also have a consequential increase in the number of receptors. And that means you should have more sites for binding, which will increase the adrenergic tone. So basically, the purpose of giving alpha blockers, we said that alpha blockers are supposed to help resolve the lower urinary tract symptoms. So that's the main reason why we give alpha blockers. They are given for symptomatic relief. And the symptomatic relief is for the signs and symptoms we talked about, the obstructive or irritative symptoms, or the obstructive or voiding symptoms, then the storage or irritative symptoms. These come together to form what we call the lower urinary tract symptoms. So that's the general term for the signs and symptoms, lower urinary tract symptoms. So basically, the alpha blockers are given to relieve the lower urinary tract symptoms. Of note, the alpha blockers do not reduce the size of the prostate. So they do not reduce the size of the prostate, neither do they reduce PSA levels. So let's take note of that. The main purpose is to relieve lower urinary tract symptoms. They do not reduce the size of the prostate, neither do they reduce the PSA levels. So we've talked about how they act. Basically, they are going to block the alpha 1 receptor. So alpha 1 receptor, you find some alpha 1 receptor on the prostate gland and the bladder neck. So once you block this receptor, you cause, basically when you activate it, it's supposed to cause smooth muscle contraction. But if you block it, it causes smooth muscle relaxation around the bladder neck and prostate. Once the prostate and bladder neck are relaxed, urine is able to flow easily. So the signs and symptoms can be relieved when you give these alpha blockers. And the alpha blockers, there are different types of alpha blockers. They are grouped under their selectivity and whether they are short acting or long acting. So let's talk about the different classes of alpha blockers that we have and the one we can use for BPH. So the first class is non-selective alpha blockers. So non-selective alpha blockers. Basically, the non-selective alpha blockers, from their name, they are not just limited to blocking alpha 1. They can block alpha 1, alpha 2. So they are non-selective. An example of a non-selective alpha blocker is phenoxybenzamine. So we have phenoxybenzamine. So we have phenoxybenzamine, which is a non-selective alpha blocker. It can block both alpha 1 and alpha 2. All right. The next class is selective short-acting alpha 1 blocker. So we have what we call selective short-acting alpha 1 blockers. And basically, the selective short-acting alpha 1 blockers. Example, we have prazosin. So we have prazosin as one of the examples. We could also have endoramine. So endoramine. I've typed there in the chat box, endoramine, prazosin, and you could also have alfuzosin. So these are selective short-acting alpha 1 blockers. Selective short-acting alpha 1 blockers. We also have selective long-acting alpha 1 blockers. So selective long-acting alpha 1 blockers. Example is terazosin. So you can have terazosin, and we could also have doxazosin. So terazosin and doxazosin. So these are selective long-acting alpha 1 blockers. And the last class is the selective alpha 1A blockers. Selective alpha 1A blockers. So basically, the alpha 1 receptors, we have alpha 1A, alpha 1B, alpha 1C. And the one you have on the prostate, or the one which is specific to the prostate, is alpha 1A. So alpha 1A is on the prostate gland. So we have agents that are selective for just the alpha 1A. So these are known as selective alpha 1A blockers. An example is tamsulosin and silodosin. So tamsulosin and silodosin. So I've also typed it in the chat box. So these are the classes of alpha blockers that we have. We said the non-selective alpha blocker. We have phenoxybenzamine that can block alpha 1 and alpha 2. Then we also have selective short-acting alpha 1 blockers. Example, prazosin, endoramine, then alfuzosin. Then we also mentioned selective short and long-acting alpha 1 blockers, terazosin and doxazosin. And the last class is selective alpha 1A blockers. Alpha 1A is specific to the prostate gland. So examples, tamsulosin, silodosin. All right. So in terms of the alpha blockers that are used for BPH, these alpha blockers, all of them can be used too, but we tend to use the ones with very little side effects. Because when you look at the non-selective ones are able to block the other receptors. And one of the issues with alpha blockers is the risk of orthostatic hypotension. So they can block alpha 1 receptor, causing vasodilatation, and that can easily drop the BP. So you can have orthostatic hypotension. So this is a class effect. However, this orthostatic hypotension is more common with the non-selective ones. You put a patient on phenoxybenzamine, the risk of orthostatic is high. So it's high with the non-selective ones like phenoxybenzamine, and even the selective ones that are long-acting, terazosin, doxazosin, they may also present with orthostatic hypotension. However, it's less with those that are selective for alpha 1A. So the alpha 1A is basically on the prostate. So the ones that inhibit just the alpha 1A, like tamsulosin, silodosin, they tend to have less risk of orthostatic hypotension. So it's more common with the non-selective, less common with the alpha 1A blockers like tamsulosin. Then they may also cause rhinitis. So that's also a class effect. Rhinitis is one of the common side effects of alpha 1 blockers. That is why when you have cold, you want to take alpha 1 agonist like ephedrine, pseudoephedrine. These are supposed to counter the effect of the alpha 1 antagonist, which causes rhinitis. So we use alpha 1 agonist to manage. So rhinitis or orthostatic hypotension are class effects. Then for tamsulosin, which is selective, silodosin, which is selective for alpha 1A, they tend to do sexual side effects. So you may have sexual side effects like retrograde ejaculation. So one of the complaints people may come up with is that if they are on tamsulosin, they can present with manifestation that whenever they have sex, they're able to reach the climax, orgasm, all right, but nothing comes out. They don't see any semen coming out. However, when they urinate, they realize that their urine is cloudy. This is what we call retrograde ejaculation. So during sex, ideally, the semen is supposed to come through the urethra and come out, right? However, if the patient is on an alpha blocker, alpha blockers like tamsulosin can open the or cause relaxation of the bladder neck. So instead of the semen going through the urethra and coming out, it rather goes back to the bladder. And you know what is in the bladder? It's urine. So the patient will have a dry orgasm, but when they are urinating, they realize their urine is cloudy. So these sexual side effects or retrograde ejaculation is more common with the alpha 1A, like tamsulosin, silodosin. However, orthostatic and rhinitis are usually more common with the non-selective ones. Any questions so far? Okay, so the preferred agents are usually the alpha 1A selective ones, like tamsulosin, because of the less risk of orthostatic and they are more selective to the prostate. So usually we do tamsulosin 0.4 milligram daily. So that's the dosing, 0.4 milligram daily of tamsulosin. Preferably, we want the patient to take it at night, even though they can take it at any time of the day. We tell them to take it at night because of the risk of orthostatic hypotension. When they are retiring to the bed, they have less effect from that orthostatic hypotension. But tamsulosin, because it's more selective to the prostate, it can be taken at any time of the day. Unlike terazosin, doxazosin, these are strictly at night because of the risk of orthostatic hypotension. So that's that for the tamsulosin. In terms of the administration, you also want them to take it 30 minutes after meals. So 30 minutes after meals, because it's been shown that after meals or 30 minutes after meals, when you are getting to the fasting state, it's been shown that the fasting state increases the bioavailability by about 30% and the peak concentration by 40 to 70%. So you take it 30 minutes after meals because fasting state has been shown to increase the bioavailability by 30%, and the peak concentration by 40 to 70%. So that's the main reason why you may want to take it 30 minutes after meals or when you've not even eaten. It can be taken because the fasting state helps with bioavailability and also peak concentration. And the maximum dose you can do is zero point 0.8 milligram. So you start with 0.4 milligram daily, but you can increase it to 0.8 milligram if the patient is not responding after 2 to 4 weeks. After 2 to 4 weeks, you can increase to 8 milligram, 0.8 milligram. All right. Any questions on the alpha blockers? All right. So let's move on to talk
Yes,
about the next class.
Doc, I have a question. Yeah,
Okay, go ahead.
Doc, please. Yeah, if we are aiming at achieving uh, higher bioavailability and peak concentration and all that, which is effective during the fasting stage, then why not they take it before meals?
Yeah, so that's why I've said that you can take it with or without meals. But in the time that you are taking it, if it's around the time that you are eating, then it's 30 minutes after meals. So you can take it when you've not eaten because the fasting state increased bioavailability by 30% and peak concentration by 40 to 70. Just that we usually tell them to take it at night after their last meal, 30 minutes after their last meal. So it becomes a habit for them so that they remember. But technically, anytime during the day, it can be taken. Any other question? All right, so let's talk about the 5-alpha reductase inhibitors. So the 5-alpha reductase, remember the etiology, we talked about hormonal influence. In hormonal influence, we said testosterone can be converted to dihydrotestosterone by an enzyme known as 5-alpha reductase. And this 5-alpha reductase enzyme, we have 3 subtypes. We have type 1, we have type 2, and we have type 3. So the type 1 we said is usually found on the scalp, the hair follicles, the liver. Type 2 is usually around the prostate and around the bladder neck. Then type 3 is found in the brain and mammary glands. So these are the locations of the 5-alpha reductase enzyme. However, when it comes to BPH, we are concerned about the type 2. Because the type 2, that's on the prostate and is responsible for conversion of testosterone to dihydrotestosterone. And we said dihydrotestosterone is 5 times more potent than testosterone. And the more you produce dihydrotestosterone, the larger your prostate gland becomes. So as part of the treatment, we develop drugs like 5-alpha reductase inhibitors. Basically, they inhibit 5-alpha reductase enzyme, preventing conversion of testosterone to dihydrotestosterone. So if you have little dihydrotestosterone in the system, you have little growth in the prostate gland. So common examples under this class is finasteride and dutasteride. So we have finasteride and we have dutasteride. Basically, these medications The rationale for giving these medications is to reduce the size of the prostate gland. So they help reduce the size of the prostate gland. They also relieve the lower urinary tract symptoms we talked about, and they also reduce PSA levels. So they reduce lower urinary tract symptoms. They reduce the size of the prostate, and they also reduce the PSA levels. So these are the reasons why we give the 5-alpha reductase inhibitors. The difference between finasteride and dutasteride is that finasteride is selective for 5-alpha reductase type 2. So it only blocks 5-alpha reductase type 2, whereas dutasteride blocks both type 1 and type 2. So dutasteride blocks both type 1 and type 2, whereas finasteride only blocks type 2. So we can't base the fact that dutasteride is blocking both type 1 or type 2 to say it's superior over finasteride when it comes to BPH, because the type 2 is what we are concerned about in BPH. In terms of efficacy, the two are comparable. So they have a comparable efficacy because it's the type 2 that you are concerned about. So dutasteride blocking type 1 is not clinically relevant when it comes to BPH. But you just have to know that type 2 is blocked by finasteride, type 1 and type 2 are blocked by dutasteride. So usually the dosing is 5 milligram daily for finasteride. So you do 5 milligram daily for finasteride, or you can do dutasteride 0.5 milligram daily. 0.5 milligram daily. For these medications, they are only introduced when you have evidence that the prostate size is very big. So usually if the size of the prostate is more than 25 grams, if the size of the prostate is more than 25 grams, then you want to initiate these 5-alpha reductase inhibitors. Or the prostate volume is greater than 30 mils. So you can use the size of the volume. If the prostate size is greater than 25 grams, you can give finasteride. Or if the prostate volume is greater than 30 mil, you can also give finasteride. In terms of the counseling points, finasteride can be excreted in semen. So one of the counseling points you want to tell people who are taking finasteride, if they are sexually active, you want them to wear a condom because the drug can be excreted in semen. If it's excreted in semen and the person happens to get the partner pregnant from that, because finasteride has teratogenic effects, the baby may be born with what we call pseudohermaphroditism. So we have this congenital condition known as hermaphrodite. So there's pseudohermaphroditism. So it's not a clear-cut hermaphrodite, but it has features that looks like the male genitalia and the female genitalia. So it's pseudo. So pseudohermaphroditism can occur in the fetus, usually the male fetus. Because we talked about the effect of finasteride, it reduces the levels of dihydrotestosterone. And these are usually responsible for the male sexual characteristics. If these are low, you may start showing feminine-like features. So you may have certain structures that look like female genitalia in the male genitalia. But it's not clear cut. So that's why you call it pseudohermaphroditism. So that's one of the counseling points you want to tell a sexually active man is to wear condom because the drug can be excreted in semen. Then the other thing you want to tell them is, especially if maybe you the health professional, you are the ward, you are a lady pharmacist at the ward. Patient is not able to swallow, BPH patient, they pass an NG tube. You can't handle crushed tablets of finasteride because the drug needs to be crushed, made into a solution form, and given via the NG tube. However, if we are there as a pharmacist, lady pharmacist, you can't handle these crushed tablets. If you happen to be the only one, then you have to wear gloves to be able to work on them. This because it can be absorbed through the skin. And that will lead to what we just talked about, the pseudohermaphroditism. So for women of childbearing ages, pregnant women, you shouldn't handle crushed tablets of finasteride. Any questions? Okay. Let's move to the next class of medications. So we also have phosphodiesterase type 5 inhibitors. So the phosphodiesterase type 5 inhibitors, these are medications we already know. And these are used for erectile dysfunction. So basically, these BPH patients, they can get erectile dysfunction from the condition itself, or even some of the medications that are used. Because when you look at the alpha blockers, one of the side effects is that they can cause erectile dysfunction. So you want to give medications to manage that. So the role of phosphodiesterase type 5 inhibitors, one, they're helping with the lower urinary tract symptoms in BPH, and they can also manage the erectile dysfunction side effects of the medications and the condition. So these are the reasons why we are doing phosphodiesterase type 5 inhibitors. So there are a lot of phosphodiesterase, but we are concerned about the type 5. So from their name, they are going to inhibit the phosphodiesterase type 5 enzyme. Basically, the phosphodiesterase type 5 is supposed to break down cyclic GMP. It's responsible for breaking down cyclic GMP. So if we inhibit phosphodiesterase type 5, we are going to cause accumulation of cyclic GMP. And cyclic GMP is beneficial in this patient because it causes the release of nitric oxide. And nitric oxide, has vasodilatory effect. It can cause smooth muscle relaxation. So that's the purpose of giving phosphodiesterase type 5 inhibitors. They block phosphodiesterase type 5 enzyme, preventing the breakdown of cyclic GMP. So if you have cyclic GMP accumulating, basically cyclic GMP would cause the release of nitric oxide. That causes relaxation of the smooth muscles and vasodilatation. So that's the rationale for phosphodiesterase type 5 inhibitors. And common examples, we could have what? What are some of the common examples under phosphodiesterase type 5 inhibitors? Any common example?
Sildenafil.
Yeah, so sildenafil. What again?
Tadalafil.
Yeah, so tadalafil. Any other? So there are a lot of them. Sildenafil, tadalafil, vardenafil. So we have vardenafil. And we also have avanafil. So vardenafil, and avanafil. So these are phosphodiesterase type 5 inhibitors, aside the sildenafil and tadalafil. The ones that have been extensively studied for BPH are the first two, sildenafil and tadalafil. So sildenafil and tadalafil have been extensively studied, but the one that's preferred is tadalafil because it's longer acting. It's preferred to use in BPH. So that is what we use mostly in BPH. They take 5 milligram daily. So that's the dose, 5 milligram daily of tadalafil. Preferably, you want them to take it at night. You know the other effects. You don't want them being uncomfortable during the day because of the other effect is causing. So it's preferred to take it 5 milligram daily at night. So we've mentioned the purpose to relieve lower urinary tract symptoms by causing relaxation because nitric oxide can cause smooth muscle relaxation around the bladder neck, and that would allow urine to pass through the urethra easily. Then the other benefit is it's also countering the side effects of the medication, erectile dysfunction, and from the BPH itself. So these medications are usually not used as monotherapy. They are used as adjunct instead. So you can use them as adjunct to the alpha blockers or the 5-alpha reductase inhibitors. Any questions on the 5-alpha reductase inhibitors? Sorry, the phosphodiesterase type 5 inhibitors.
Hello, sir.
Yeah,
Good evening.
good evening.
Sir, please, with the 5-alpha reductase inhibitors, with the side effects that you said that it is teratogenic and it causes pseudohermaphroditism. So in this case, does it mean that if a patient has BPH, he can't give birth?
All right, so if a person has BPH and they are planning on giving birth, this for the men because the men are taking finasteride. So if they are
Yes,
planning on
please.
giving birth, then they have to switch them from finasteride. So they have to stop the medication. And when you stop the medication stays in the system for long. Usually, we recommend that after stopping 6 months after, that's when you can begin thinking of conception. But within the 6 months, you still need to use the barrier method like condom because the drug can still have traces being excreted in the semen. So because it's in the system for long, preferably you have to allow a 6 months period before you can think of conception, trying to give birth and all that. So they can actually do, but they have to stop the medication because of the risk involved.
All right. Thank you, sir.
Okay. All right, so let's move on to the next class, anticholinergics. So anticholinergics, basically these medications are supposed to block the cholinergic receptors. So cholinergic receptors, you have muscarinic and nicotinic. But for the purpose of our discussion, it will be muscarinic because we are talking about BPH. It's the muscarinic receptors that we are concerned about. So for cholinergic effects, you know them already as sludge. So when you have acetylcholine binding to these muscarinic receptors, they can cause the sludge that we know. So S for salivation, L lacrimation, U urination, D diarrhea, G gastrointestinal distress, then E emesis. So one of the cholinergic effects is urination. However, we are saying that in BPH we can give anticholinergics So if we are giving anticholinergics, they are doing the opposite of urination. They are rather retaining urine. So I asked myself, would we have any benefit from giving anticholinergics in BPH? Wouldn't it rather worsen? Because the patient may be struggling with passing urine and all that. So why the use of anticholinergics? So for the use of anticholinergics, you have to be careful in BPH. Before you put a patient on anticholinergic for BPH, you should know the post-voidal residual volume. So we have what we call post-voidal residual volume. So from the name, post-voidal residual volume. So post-voidal means afterwards urination. And residual means what is left. So residual volume, post-voidal residual volume. So when you are done urinating, you have some urine left in the bladder. For males, the normal post-voidal residual volume averagely is around 12 ml. So you should have 12 ml of urine left in the bladder when you are done urinating. That's the average, 12 ml. However, for BPH patients, because they are struggling with urination, they are likely to retain more than the 12 ml. So they are struggling to urinate, so they are likely to retain more than what? The 12 ml. So before you put a patient, because the anticholinergics, basically, they are going to block muscarinic receptors around the bladder neck. And when you block muscarinic receptors around the bladder neck, you are going to cause retention of urine. So what we are concerned about is acute urinary retention. That's why we are talking about the post-voidal residual volume, what is left in the bladder after urination. If you calculate the post-voidal residual volume and is greater than 250 to 300 ml, the post-voidal residual volume is greater than 250 to 300 ml, then you should avoid these anticholinergics. So you can only use it in patients with BPH whose post-voidal residual volume is less than 250 to 300 ml. So that's the first recommendation. The second one is you use it depending on the type of symptoms the patient is presenting with. We mentioned storage or irritative symptoms, then obstructive or voiding symptoms. We only use anticholinergics in patients with bothersome, irritative, or storage symptoms not resolving with conventional medications. So the patient has storage or irritative symptoms not resolving with the conventional medications like the tamsulosin, the finasteride, the tadalafil. If it's not resolving with these conventional medications, then you can consider anticholinergics. And this makes sense because the issue with the storage or irritative symptoms is inability to store urine. So they tend to have urinary frequency almost every time they want to go to the washroom. So when we give anticholinergics do the opposite of urination because there is what? Urination. So opposite of urination is retention. So urinary frequency will be resolved because now you tend to retain the urine. So when you want to go, then you go. So it helps with retention of the urine. The same way, if you are always having nocturia, waking up several times at night to go and urinate, when you give anticholinergics, you are able to hold the urine longer at night before you think of even going to the washroom. And also for patients with urinary incontinence, where they are not able to control their bladder, very little urine, and is already soiling their pants and all that. So anticholinergics helps in that regard. So the recommendation is you use it in patients with bothersome, irritative, or storage symptoms not resolving with other conventional medications. Or you can use it in patients who have post-voidal residual volume less than 250 to 300 mils. If it's greater than 250 to 300 mils, then you avoid anticholinergics. So common examples we have under this class is oxybutynin. So you can use oxybutynin. You could also use sulfenacin. And we can also use tolterodine. So I've typed them in the chat box. Sulfenacin, oxybutynin, and tolterodine. So these are some examples of the anticholinergics we can use. Any question? All right, let's talk about the last class that can be used. The last class is the beta-3 agonist. The beta-3 agonist. So for beta-3 agonists, basically they activate the beta-3 receptor. And you find beta-3 receptor around the bladder neck. It's around the bladder neck and also around the prostate gland. So for beta-3 receptor, when you activate beta-3 receptor, it causes smooth muscle relaxation. And when you have smooth muscle relaxation, that means the urethra opens up. You have urine going through easily. So it helps to manage the lower urinary tract symptoms. So it's also used to manage lower urinary tract symptoms, usually for patients with irritative symptoms, just like anticholinergic. However, these medications find use in patients who cannot take anticholinergics. So you mentioned that if the patient post-voidal residual volume is greater than 250 to 300 mils, you avoid anticholinergics. In such patients, if they are not responding to other conventional medication, you can consider beta-3 agonists because they can do the work of the anticholinergics without causing urine retention. So that is the role of the beta-3 agonist. And common example we have under this class is mirabegron. So there's a drug known as mirabegron. So I'm typing it in the chat box so that you see. So we have mirabegron. So mirabegron is one of the examples of the beta-3 agonist. And basically, we said it activates beta-3 receptor around the bladder, neck, and prostate, causing smooth muscle relaxation and easy passage of urine. So these find use in patients who cannot take anticholinergics. The usual dose for mirabegron is 25 milligram TDS. So you can do 25 milligram TDS for mirabegron. So these are the 5 classes of medications we can use to manage BPH. So that's pharmacotherapy. So we talked about watchful waiting pharmacotherapy. The last one is surgery. So for surgery, you know the issue is because of the enlarged prostate. That's why you're having all these signs and symptoms. So the person has taken all these medications not having relief, the prostate gland is very large, they may resort to surgery. And surgery, they can either do a transrectal prostate resection. So they can go, there's an instrument that can be passed through the rectum. So they can do a transrectal prostate resection. So removing a part of the prostate, or they can do transurethral. So they can go through the urethra. So transurethral prostate resection. So these are the surgical methods that can be done. At times, they also remove the testes in addition because that's where the testosterone is being produced from. So they do prostatectomy and they also do orchidectomy. So prostatectomy is the removal of the prostate. Or they can do orchidectomy. Orchidectomy is removal of the testes. So these are the surgical methods that can be done in patients that you are doing surgery. So you can do transurethral resection of the prostate gland or transrectal resection of the prostate gland. And the other option is you can do prostatectomy with orchidectomy. So you do removal of the prostate, either transrectal or transurethral. Then you can also add orchidectomy, where they remove the testes in addition. So these are the surgical methods that can be done for BPH. Aside these, there are adjunctive medications on the market. These are supplements. So you see Prostacare, Prostamax, Prostacure, Prostis, all these are prostate supplements. The main ingredient in most of them is saw palmetto. So we have saw palmetto and also proton. So proton membranaceous and saw palmetto. These are the main ingredients that you have in these products. The
Dr. Isha, please, I didn't hear
evidence
the
surrounding
correct
the
ingredient.
okay, so I've typed them. So saw palmetto and proton membranaceous. So these are phytotherapy. They are ingredients that are obtained from plants. So there has been a lot of studies around these agents as phytochemicals that can be used in BPH. The evidence surrounding them is not really strong to recommend routine use of these medications. So what we know is that for the saw palmetto, it acts just like finasteride. It's able to block the 5-alpha reductase enzyme. So just like the finasteride, that's how saw palmetto acts. So just the evidence is not strong, so we don't routinely recommend them. Hello.
Hello, Doc.
Yeah. Sorry, I received a call, so we couldn't continue. But that
No
was the last
problem.
bit of the discussion. We talked about the watchful waiting, the pharmacotherapy, the surgery options, and phytotherapy. So, do you have any questions on what we've talked about so far? If there are no questions, I have some. So I'll send it to you so that we quickly go through them.
Okay, sir.
Okay, so I've sent you the questions. You can share your screen so that we go through them. Is someone sharing their screen? Okay, so
Yes. So, question 1. All the following are functions of the prostate gland except A. Produces PSA. B. Aids in washing the sperms. C. Produces pre-ejaculatory fluid. D. Produces fluids that neutralize the harsh acidic environment in the vagina.
all right, so what are we going for?
C.
B.
Okay, I'm hearing B, I'm hearing C. So which one are you going for?
C.
Yeah, so C. So the prostate gland produces prostatic fluid. However, pre-ejaculatory fluid is produced by the Cowper's gland. So the Cowper's gland produces pre-ejaculatory fluid.
Two. Prostate cancer originates from which zone in the prostate? A. Transition zone. B. Peripheral zone. C. Fibromuscular zone. D. Central zone.
B. Peripheral zone.
Yeah, so peripheral zone. So we said BPH originates from Okay, I think that was answer the third one. But prostate cancer is from the peripheral zone. All right, let's move on.
Okay, see. BPH originates from which zone of the
I can't
prostate?
really hear the answers.
So which zone?
A.
A.
Putin zone.
So BPH is from the transition zone. So transition zone BPH. Peripheral zone is prostate cancer.
Okay. 4. One finger breast units during the DRE is equivalent to A. 5 to 15 grams of prostatic tissue, B. 20 to 25 grams of prostatic.
D.
Okay, so what are you going?
D.
D.
20 gram.
Yeah, so D. Yeah, 15 to 20 grams of prostatic tissue.
5. All the following are clinical indications of finasteride except A. Alopecia, B. Prostate cancer, C. Hirsutism, D. BPH.
Okay, so what are you going for?
Hirsutism.
C.
Okay, I'm hearing C, hirsutism. Is everyone going for C?
B.
What is B?
Prostate cancer.
Yeah, so prostate cancer. We don't use finasteride in prostate cancer. You can use it in BPH. You can use it in hirsutism. Hirsutism basically is male pattern hair growth in females. So you have a female having a male pattern hair growth. So you know where the male pattern hair growth is. The beard, the mustache, the facial hairs. So these are male pattern hair growth. So we don't expect females to have these type of hair growth. So if you're having mustache, you're having beard, a lot of facial hair, that's hirsutism in females. And basically it's because they have high levels of testosterone. For hirsutism, you can give finasteride to manage the hair growth. Once it reduces 5-alpha reductase, prevents dihydrotestosterone from being produced, we have low levels of hair growth. So that's why we use finasteride. But the female shouldn't have any plans of getting pregnant anytime soon. If they want to conceive, then that means you have to stop the finasteride, then switch to something else. That will be safe for the conception.
Okay, thank you. 6. Which of the following is not a selective short-acting alpha-1 blocker? A. Doxazosin, B. Alfuzosin, C. Endoramin, D. Prazosin.
Okay, I'm hearing any other answer. So the answer is C, solodocin. So solodocin, because it's more selective to alpha 1A, likely to do the retrograde ejaculation.
8. Which of the following is not a storage symptom in BPH? A. Nocturia, B. Postvoidal dribbling, C. Urinary frequency, D. Urinary incontinence.
B.
Which one are you going for?
Post-voidal.
Yeah, post-voidal dribbling. That is an obstructive or voiding symptom. It's not storage.
And Mr. Morale is a 67-year-old man with cataract who has been scheduled for surgery. He is also taking tamsulosin for his BPH. Which of the following is he at risk of? A. Orthostatic hypotension. B. Retrograde ejaculation. C. Blindness. D. Floppy iris syndrome.
D. D. D.
Okay, what are
Floppy
you going for?
iris.
Floppy iris syndrome.
Yeah, so floppy iris syndrome. So usually for patients on alpha blockers who have been scheduled for cataract surgery, we want them to discontinue the alpha blocker before the surgery because of the risk of floppy iris syndrome. And basically, this is a surgical condition that they see during the surgical procedure. It's basically a clinical trial. With a clinical trial, it consists of iris prolapse. You could also have flaccid iris, and you could also have pupil constriction. So we have pupil constriction, iris prolapse, and flaccid iris. So before you do, they usually do the cataract surgery. They usually give some eye drops, and these drops they can give cyclopentolate eye drop or tropicamide eye drop. These are usually agents that are given to dilate the pupils, tropicamide or cyclopentolate. Realize that if the patient is on alpha blocker, irrespective of the number of times they give these eye drops, they wouldn't achieve the pupil dilatation they want. So there's progressive pupil constriction, and that can lead to iris prolapse during the surgery and also flaccid iris. So if you have that, we call it the floppy iris syndrome. It's a triad of these symptoms that I've talked about. Let's move.
Okay, thank you. 10. Which of the following agents has a lower risk of orthostatic hypotension? Hello?
Yeah, I can hear you.
Hello?
Yeah, we can hear you.
Okay. Okay. A. Silodosin. B. Terazosin. C. Prazosin. D. Doxorubicin.
Which one are you going for? A.
A.
So A, silodosin, because it's more selective to the prostate.
Hematuria associated with BPH. Prostate size greater than 25 gram.
Okay, so what are you going for? Which one are you going for? Hello, Hillary. Hello. I think Hillary is not here. Who can share their screen? Hello, is anyone sharing their screen? Hello. So you all have the
Hello,
question.
sir.
So you all have the question. So let's move on. If none of you is sharing their screen, let's move on. So which question are we now?
Question 11.
Okay. So what are you going for? Question 11.
C.
Did I hear D?
No, C. C. Hematuria associated with BPH.
Yeah. So all of them are indications except hematuria associated with BPH. When you have hematuria, then you think about something else. It could be malignancy, bladder cancer, and all that. But the indications for finasteride use is for prostate volume greater than 30 ml, PSA level greater than 1.5, or prostate size greater than 25. These are the indications to put the patient on finasteride. Okay, let's move on. Someone should read first.
Number 12. Finasteride increases the chances of high-grade prostate cancer. True or false?
Okay, so is it a true or false statement?
True.
Is it a true or false statement?
True.
Yeah, that's a true statement. So the issue about finasteride, you remember when we were talking about the 5-alpha reductase enzymes inhibitors, we mentioned that they help lower urinary tract symptoms. They also reduce the size of the prostate and reduce PSA levels. The PSA levels, we mentioned that it's not specific to the BPH. It can be elevated in prostate cancer, prostatitis, and all that. And one of the methods we screen for prostate cancer is using the PSA levels. So if the person has BPH and is on finasteride, and they happen to have prostate cancer as well, prostate cancer may be masked by finasteride because finasteride will lower the PSA levels such that if they come to the office visit and the doctor checks PSA levels within the normal range, he assumes that this patient is not at risk of prostate cancer. So by the time they realize the patient actually has prostate cancer, the patient would have been well advanced in the condition. So we say finasteride increases your chances of high-grade prostate cancer because it sort of masks the early signs and symptoms by lowering the PSA levels. So that's why there's high chance that you may develop high-grade prostate cancer if you don't really screen for the patient well if they are on finasteride. So before you even put the patient on finasteride, try and rule out prostate cancer. Then you can put them on finasteride. All right, let's move on.
Number 13. Why tamsulosin is taken 30 minutes after meals?
So why do you take it 30 minutes after meals? Why is it taking 30
Okay.
minutes after meals?
So please, according to what we heard today, after 30 minutes after meals, there is a fasting state. So it increases the bioavailability of the drug by 30% and also increases the peak concentration of the drug by 40 to 70%.
Okay, so that's true. So that's why we take it 30 minutes after meals. All right, let's move on.
Match the following to the statements below. So we have A, sulfenacin, B, finasteride, C, tamsulosin, D, phenoxybenzamine, E, mirabegron. So number 14 can cause pseudohermaphroditism in fetus.
So which of them can cause pseudohermaphroditism?
Finasteride.
Yeah, so finasteride. All right, the next one.
Beta 3 agonist.
Which of them?
Mirabegron.
Yeah, so mirabegron, beta 3 agonist. Okay.
16 only used in BPH when the prostate residual volume is less than 250 to 300 ml.
Okay, so which one do we use when the post-voidal residual volume is less than 250 to 300 mils?
Sulfenacin.
Yeah, sulfenacin, which is an anticholinergic. Okay.
17 used in pheochromocytoma.
Which of them do we use?
D.
Phenoxybenzamine.
Yeah, phenoxybenzamine. Phenoxybenzamine. So pheochromocytoma, we use alpha blockers. And the alpha blockers we've been using is phenoxybenzamine. Let's move on.
Number 18, all the following are recommended therapeutic options for BPH except A, surgery, B, phytotherapy, C, watchful waiting, D, medical therapy.
Okay, so which one are you going for? Which one are you going for?
Phytotherapy.
Yeah, so phytotherapy. You said the evidence is not strong to recommend it for routine management. So the three options: surgery, watchful waiting, and medical therapy. Okay, let's move on.
Number 19, why castrated males do not develop BPH?
Yeah, so why is it that castrated males do not develop BPH?
So you said that the dihydrotestosterone and testosterone are able to stimulate the androgen receptors in the prostate gland, which leads to high risk of developing BPH. And these sources are from the testes. And then in castration, where the testis is removed, means there's lower risk of the BPH.
Exactly. So castrated males, usually when they are castrated before the age of 40, they are highly unlikely to develop BPH because the hormone that drives the growth of the prostate is the testosterone, and the testosterone is produced from the testes. For castrated males, their testes have been removed, so they are not producing enough levels of testosterone for it to be converted to dihydrotestosterone that will cause the increased growth of the prostate. So they are highly unlikely to have BPH. All right, let's move on.
Number 2, points for a sexually active male taking finasteride.
Okay, so what's the counseling point?
So he'll be counseled to use to wear a condom before having sex because finasteride is excreted in semen. So we want to avoid him transferring that semen to a woman who might end up having a child with hermaphroditism.
All right, so that's true. So they should wear condom to prevent the finasteride getting into the female to cause pseudohermaphroditism in the fetus. All right, let's move on.
Use the preamble below to answer the following questions. A patient on tamsulosin for BPH complains of having issues with his sexual life. He complains of having sex to reach climax or orgasm, but appears to have no or little semen coming out. 21. What medical condition is this?
Yeah, so what clinical condition?
That's
Retrograde
ejaculation.
ejaculation.
Yeah, so retrograde ejaculation. Okay, let's move on.
22. He also complains of having a cloudy urine. Any explanation for this?
Yeah, any reasons for that? Any reasons for that?
So we said the retrograde ejaculation is specific for the selective 1A blockers because they are going to relax the alpha receptors on the smooth muscle. So when that happens, the semen can go back into the bladder. So that will mix with urine, making the urine.
Exactly so. So the alpha 1 blockers can cause relaxation of the bladder neck, and that will cause a backflow of the semen into the urine, mixes with the urine in the bladder. That appears as the cloudy urine the patient is having. Okay, let's move on.
How can this be managed?
Well, how do you manage it? How do you manage retrograde ejaculation?
Periton.
Okay, so usually the first thing you do is that you stop the offending agent. In this case, the offending agent is tamsulosin. So you can switch from tamsulosin because we said the issue is more with the selective alpha 1A, even though it can occur with the other alpha 1 blockers, but it's more with selective alpha 1A. So you can switch from tamsulosin to maybe alfuzosin, terazosin, doxazosin. If you switch and the patient is still not having the effect, then you can give agents like what you just mentioned, chlorpheniramine, which is Piriton. You can give chlorpheniramine, or you can do alpha 1 agonist. This side effect is caused by alpha 1 antagonist. So you can give alpha 1 agonist to counter the effect. So usually you can do ephedrine, pseudoephedrine. So we have pseudoephedrine available on the market, Sudafed. So you can give pseudoephedrine, you can do ephedrine, you can do the anticholinergics, antihistamines with anticholinergic effect, like Piriton. So these can be used to manage the retrograde ejaculations. Okay, let's move on.
24. Is it a class effect? Which drugs are the usual culprits?
All right, so is there a class effect? And which of them is the usual culprit? Any ideas? We've talked about it.
Please, it's a drug effect, not a class effect, because not all the alpha blockers
We couldn't really hear you.
I think it's rather a drug effect, not a class effect, because not all the alpha blockers ejaculation. It's only those that are selected for the alpha 1A receptors.
Okay. It's actually a class effect. All the alpha 1 blockers can do it. Just that it's more pronounced with the ones that are selective for alpha 1A. So it's more pronounced for the ones that are more selective for alpha 1A. So it's a class effect, but the usual culprits are the selective alpha 1A. So the tamsulosin, silodosin, they tend to do it more. But all of them can do it. That's why sometimes you switch from tamsulosin to alfuzosin, terazosin, you may still have that. So you manage with the alpha 1 agonist or the agents that we talked about to manage the retrograde. So it's a class effect.
Use the preamble below to answer the following questions. A BPH patient who on tamsulosin 0.8 milligram daily presented with symptoms of non-resolving urinary frequency, urinary urgency, and nocturia. A trans-abdominal ultrasound was done, which showed a post-voidal residual volume 115 mils per minute with a prostate volume 55 mils. 25. Which set of BPH symptoms is the patient?
Okay. So which set of symptoms is the patient demonstrating?
Storage symptoms.
Yeah, so storage or irritative symptoms.
26. Which medication could be added to help with patient symptoms?
Okay, so which medication can we add? So the person is on maximum daily dose of tamsulosin, still has non-resolving storage or irritative symptoms. So which medication can it be?
The anticholinergics.
Yeah, so the anticholinergics. So if we have non-resolving irritative or storage symptoms on the conventional medications, we can do the anticholinergics. Okay. All right, let's move on.
27. Patient complained of seeing a shell-like capsule in his stools with no drug. Which medication could have been added in 26?
Okay, so which medication could have been added? For which reason the patient complains that they see this shell-like capsule and there's no drug in it. So they usually call it boost tablet. So which medication?
Oxybutynin.
Yeah, oxybutynin. So oxybutynin that are formulated as Oros preparation. So we have what we call Oros. Oros is osmotic controlled release oral dosage form. Oral dosage forms. So osmotic release oral systems. That's Oros. I've typed it in the chat box. Basically, it's a capsule. You have the drug formulated in the form of osmotically active substance. So when you ingest, the drug is able to be released through the pore. So you realize that the patient may complain that they are seeing capsules that they took in their stool. However, the capsule may be empty. So because it's formulating of an oral preparation, you are likely to see that capsule in your stool. So we always advise them not to be alarmed whenever they see this, because that's how the drug is formulated. So you see these capsules in your stool, but it doesn't mean that the drug wasn't active or wasn't absorbed. All right, let's move on.
28. Is the added medication appropriate?
Yeah, so is it appropriate to have added oxybutynin? Appropriate. Yeah, so the patient has non-resolving irritative or storage. So that's an indication to start oxybutynin volume is less than 250 to 300 mils. So the patient qualifies to be on oxybutynin. So it's appropriate.